Speaker is going to be Dr. Munier Nazzal, and the topic is tips.
Thank you again for inviting me to this conference and being part of the conference. After Stefan lecture, so I'm going to talk about tips for venous thrombectomy. I want to start by saying lysis is almost dead, actually. There's no indication almost for lysis now. So these are the reasons we do DVT removal, clots removal, which is improve symptoms, reduce PTS, and preserve the valves, which is also with the PTS. The problem with the PTS is difficult to define. Nobody agrees what is the incidence. And the reason because we have a mixture of problems when it comes to DVT, proximal, isolated, and femoral-popliteal. That's why the other two studies, they included femoral-popliteal veins, so the results not great. This is the treatment, we all know it. The first way to remove venous thrombectomy is the surgical. Again, this is dead. The only advantage of the surgical removal is really to add the fistula, and the fistula increases the blood flow. The reason I'm saying it is dead because it takes a longer time, a lot of complications, and you can achieve the same result by percutaneous thrombectomy in a very short period of time. So these are the treatment options: surgery versus endovascular, pharmacomechanical versus mechanical, endovascular, which device to use. So I'm going to use those tips for the percutaneous thrombectomy, not the open. The first step, you need the proper indication. Actually, at the foot of the lecture by Stefan, I'm going to tell you, if you do it for the wrong indication, you will not achieve the symptom relief and you will not achieve the PTS. And the indication from all the studies, only iliofemoral. Only iliofemoral. All others, but of course that includes the inferior vena cava. All others are not really part of the treatment, although our colleagues from cardiology and interventional radiology, trying to do it. And we stop them actually in many areas. You have to have a special permission to do it with a good indication. The second thing, tip number 2, don't chase complete resolution of the clot, because most of the studies, there was no relationship between full resolution of the clot and the PTS. So achieve as much as you can, opening the blood flow, removing as much as you can do of the clots, and especially if it is an iliofemoral area, make sure there is a good flow. That's what you need to do. Tip number 3, if you are in doubt, the patient has no reason to get DVT, get a CT scan, abdomen and pelvis with a venous phase, because in many cases, even young people, we discover so many patients with lymphomas, leukemias, large lymph nodes, tumors. We published a case even of a diverticulum of the bladder causing the DVT. If in doubt, get a procedure CT scan. It helps you also to decide if the IVC is included or not. If you want to do thrombolysis, try to minimize the time and the ICU state and reduce the bleeding. The best thing to do, pulse spray followed by suction. And the suction, in many cases, people use angiojet, but angiojet again is being not favored because of the acute renal failure. Tip number 4, kidney protection. If you decide to do angiojet or any clot removal in a very swollen leg, you need to work on kidney protection, and that is before you go to the surgery, including hydration, sometimes giving other medications or giving bicarbonate, or after the procedure, give the patient a lot of fluids. Venous access is very important. If you are going to do lysis or a pulse spray, anytime you think you will use lysis, try to do one stick. If you do multiple sticks, you will get bleeding. If you hit the artery, you might need to abort because you cannot lyse with a hole in the artery. And you have to have the best ultrasound you have. Not all patients are easy to navigate with an ultrasound, especially the type of fat is important, and also if the patient is obese or not is very important. The depth of the ultrasound should be acceptable, and you have to find an area where there is a good flow. So you cannot go through the clot thinking the blood flow through the clot will keep the area that you open. So you need to go an area with a clot. We usually use actually the popliteal vein or distal. Typically we say go to the most distal or most proximal, the way you want to say it, that has an open blood flow. The access sheath, don't worry about the sheath in the vein. You can go up to 18, 20, nothing will happen. As much as you want, but try to use the smallest sheath to achieve your goal. Crossing the thrombus. Negotiate, don't force. Because if you penetrate the vein and it happens, and if you end in doing lysis, which hardly we do lysis now, you are going to bleed. Negotiate, don't force it. Soft wires, much better than stiff wires. Hydrophilic and low profile tapered catheters will help. A combination of wire and catheter is very important. Stuck at the left common iliac vein, keep it trying, you will get through it. If it doesn't go through it, lyse it for a short time, and then you will go through it. Beware of being in a collateral, that happens a lot. If stuck, lyse first, and then once you go through the vein, make sure you are in the inferior vena cava. Don't assume you are in the vena cava, because some of the collaterals are large and run parallel to the cava. If you don't want to use ultrasound, intravascular ultrasound, you will actually stent much less than indicated. So you need to use an ultrasound, intravascular ultrasound. Don't look for clots, look for stenosis with the intravascular ultrasound, measure the vein size and measure the area, and identify anything that has more than 50% stenosis. Area reduction, I'm talking about, not diameter reduction. And assess the external compression. You can see external compression in many areas. Don't assume external compression by artery or anything is only on the left side. The right side can be compressed. The question, no filter or a filter, the answer is no filter. Unless there's a free-floating clot or there is an IVC extension and you are worried about embolizing. Most of the time, our indication was 1% actually filter use. We don't use filters. If you end in using a filter, it has to be a removable filter, so you remove it later. When you use a catheter or a sheath that you will use to suction, use an angled tip catheter or sheath, because your goal is the wall, not the hole. That we always tell the reason is the wall, not the hole. The wall, you need to remove the clot from the wall, so you have to have an angled tip catheter, and you can sometimes cross to the other side if you want to do one hole access. Stent or don't stent, you need to err on the side of stenting, not stenting. The reason for that, if you under-stent the number of stents, there is a high recurrence. If you suspect there is a stenosis more than 50%, please go ahead and stent. Most of the time there is a stenosis. And if you are not sure, balloon the area. If there's wasting, you know there's a stenosis. Then you can go ahead and stent after that. The question is which device? The answer, whatever you have and can afford, whatever you master also. Not everybody is great in everything. We did our study. We looked at different devices, including Terelis, angiojet, catheter-directed lysis, at the end, patency, PTS. There was no difference between all of them. And a study that we took about 5 years. And if you follow the indication, there's hardly any difference between all of them. There are so many devices for thrombectomy. I'm just showing them to here. Some of them will protect, some of them will injure, some of them have no effect at all. But the two most used ones, in the US at least, the penumbra and the inari. The penumbra, automated suctioning under high pressure. The inari, it can be a vacuum suctioning, or it can be the stent that will remove the clot. All of them remove clots, acute and chronic and subacute, if you want to use the word subacute. But there are a few differences between them. You have to familiarize yourself with all devices. Which one is better? This is my opinion. No publication, based on the using of both, the penumbra blood loss can be transfused again. In the inari, you cannot transfuse it. It is less torqueable than the inari, and large sheath, both of them large, but in the case of the penumbra, you don't have a dilator. This is the problem. They said it will come soon, the dilator. The inside catheter cannot be good if you want to use the catheter for guiding it to different angles because of the shape. You can, but it's not as easy, and is not as good for chronic clots like the case of inari in our hands. It is very expensive. As for the other one, blood can be transfused, and the other one is actually the inari, because you suction and give the blood after filtering it. Large sheath like the other, has a dilator. Basket to capture clots is much better than suctioning in our hands, and many people actually, not even us, the other groups. It is cumbersome though. It takes a much longer time than the penumbra. The catheter is softer than the penumbra. It is efficient with the chronic clots. You can remove really good chronic clots. The other thing, you can cheat by identifying the area of stenosis. When the stent itself that you pull the catheter or the basket become narrow at certain area, you know there is a stenosis. It is very expensive, of course, and it is non-automated. That's the problem with it. So the other one is automated. Both of them will cost about $20,000 in the United States, but everything is exaggerated there. And the reimbursement is about $27,000, $28,000. It's why they are pulled from many markets. Thank you very much.